Hello and welcome to the medical volunteer training for Special Olympics USA Games Orlando 2022. My name is Dr. Matthew Holder, and like you, I am a volunteer, though I've spent most of my career taking care of people with intellectual and developmental disabilities. I am the CEO of Kramer Davis Health, which is an organization that provides interdisciplinary care to people with intellectual and developmental disabilities. I'm the co-founder of the American Academy of Developmental Medicine and Dentistry and the National Curriculum Initiative in Developmental Medicine, which means that I have taught about this area in a number of medical schools around the country. Also one of the co-founders of the American Board of Developmental Medicine, which is a new specialty in the care of adults with intellectual and developmental disabilities. But most relevant to this presentation, I spent 16 years as the global medical advisor to Special Olympics International. So Special Olympics is a large organization. In pre-pandemic times, we had over 100,000 competitions around the world each year, 32 different types of sports, over 1 million coaches and volunteers, over 6 million athletes. One thing that I think it's interesting to note about our athletes is about 30% of them are over the age of 35. We really take all ages in Special Olympics. One thing that's a little different about Special Olympics compared to other sports organizations is that Special Olympics is about achieving a personal best, not necessarily a world best, but a personal best. And so we have different levels of play for people's varying abilities in intellectual and developmental abilities. So what we're looking at is a group of people who have significant variation. And so in order to make that play as fair as possible, we have different divisions. And you'll see all kinds of age ranges. At the games, typically our average aged athlete is about 24 years of age. Aside from athletes who have intellectual disabilities, we will also have a number of athletes who do not have intellectual disabilities. These are called unified athletes in our vernacular. And they are going to play side by side with our athletes who have intellectual disabilities. Another term you might hear around Special Olympics is athlete leaders or athlete leadership program. Special Olympics is more than just a sports program. Of course, we have a lot of health offerings we'll talk about here during this presentation. But one thing we also really like to encourage our athletes to do is to hold meaningful roles in society. So we work with them to be on boards and to be public speakers and to be sports officials and photographers and really take part in all kinds of aspects of life. The Healthy Athletes program at Special Olympics has been around since 1997. We've done over 2 million health screenings. There's 8 different disciplines here: fun fitness, fit feet, health promotion, healthy hearing, opening eyes, special smiles, MedFest, and strong minds. Here are the logos for each one of those disciplines. You'll see those disciplines at the Healthy Athletes venue at the USA Games, all except for MedFest. And that is because most of the sports physicals, or all of the sports physicals for our athletes, will have occurred prior to the games starting. Some of the results that we've found when we've done these millions of screenings on people with intellectual disabilities is that, are here on this slide, lots of unmet health needs. As you can see, 38% failing in eye health. I think the next one is really stands out to me is 14% are in dental pain as they're trying to participate in Special Olympics. That's a pretty staggering number when you think about it. About a quarter are failing their hearing exam, 60% almost are overweight or obese. We have lots of bone density issues that we detect. Again, this is a relatively young population, and a quarter of them have low bone density issues. Significant needs in improvement for flexibility or gait. And also a quarter of the athletes are taking some kind of medication that can adversely impact the athletic experience. So I want to go through and talk a little bit about definitions that you may hear, and to try to demystify what intellectual disability is and some of the medical issues that we'll see in this population. The first thing is the definition of intellectual disability, and I won't read the whole thing here, but the definition in a very basic form is having an IQ that is lower than 70 or 75, with some co-occurring issues in adaptive behavior. That's the basic definition of intellectual disability, and everybody at Special Olympics will meet that definition. Another term that you might hear is developmental disability, and you might hear me use the term intellectual disability or developmental disability or ID or even IDD. And when I use those terms, I kind of use them interchangeably for the purposes of this presentation. But a developmental disability is a broader term, broader than intellectual disability. Intellectual disability is a developmental disability. But there's a federal definition, and typically what that means is that it has manifested before the age of 22. To give this a different medical context, I'd like to show you this slide. Now, this is my attempt at a Venn diagram, these squares and rectangles here, and they're drawn relatively to scale in terms of proportionality in the population. If you look at the size of the screen here, the yellow or the whitish yellow box of the screen, which is developmental disabilities, that's about 5% of the US population. Within that, then you will see the next largest box here is the box of intellectual disability. This is the blue box. And this would represent about 1 in 44 people, about 2.3% of the population have intellectual disability. Another diagnosis that you've undoubtedly heard of is autism. And this is a slightly smaller group, although it is catching up in number to intellectual disability. And as you can see, there's a significant amount of overlap between autism and intellectual disability. Though it doesn't necessarily mean that you have intellectual disability to have autism. The reality is that you can have both. The next most common diagnosis that we'll see in this area is cerebral palsy. As you can see here in the overlap, it's possible to have cerebral palsy, intellectual disability, and autism all in the same person. Although a lot of people are surprised to learn that just because you have cerebral palsy doesn't mean that you have intellectual disability. In fact, the majority of people who have cerebral palsy do not. And this would represent about 1 in 320 people or so. Down syndrome is probably the next most common diagnosis that we hear in this field. It's about 1 in 700 individuals. And in Special Olympics, we see a lot of people who have Down syndrome. About 15% of our athletes will have Down syndrome. The next most common diagnosis is fetal alcohol syndrome. It's about 1 in 2,000 people or so. Then there's Fragile X syndrome, which is the next one after that. And that would be about 1 in 3,000 people, depending on the gender of the person that we're talking about. What I want you to notice here is that with each box that I talked about, the boxes got successively smaller. And what's interesting here is I could keep going down this list about 300 or 400 more times, maybe even 1,000 more times. Each one of these boxes would get smaller and smaller and smaller. And these would be diagnoses that were very rare and that most people hadn't heard of. And this can be somewhat distressing to medical volunteers who are trying to think back to medical school or medical training and drawing a big blank on a syndrome that maybe they haven't heard of. And sometimes that can be a little bit intimidating. What we're going to try to walk through here is a way to look at our athletes so that the rarity of the syndrome that we're talking about doesn't really throw you off. So just to give a couple of examples of what may cause intellectual or developmental disability here, birth trauma, infection, traumatic brain injury, these are acquired neurodevelopmental disorders. And then here's a very truncated list of some of those more rare syndromes that I was talking about, but literally there are at least 1,000 more, and there are more being discovered every single day. But what these syndromes all tend to have in common is up here on this chart. And I realize this is a little bit of a complicated chart, but what we're looking at here is the threshold concept is that everybody who has intellectual disability actually has a neurodevelopmental disorder. And that neurodevelopmental disorder either comes from some sort of environmental insult to the developing brain or genetics. And a neurodevelopmental disorder will result in a number of things, and they can all co-occur to some degree in the same person. So, of course, all of our athletes will have intellectual disability, but a good number of them, about 25%, will have some kind of neuromotor dysfunction, seizure disorder, or sensory differences like hearing impairment or vision impairment, or sensory hypersensitivity, which like light or sound hypersensitivity, which you might find more in autism. Communication difficulty is also quite common in people with neurodevelopmental disorders and psychiatric and behavioral issues. In addition to this, a number of the syndromes that we're talking about here will affect the development of other organ systems in the body. So I've just listed some here. In the sports context, we tend to be most concerned about things that impact the heart and the lungs, the musculoskeletal system, and the nervous system as well. Just as an example, in my clinic, when I'm looking at people with intellectual and developmental disabilities and trying to summarize for myself what they sort of look like from a medical profile, this is typically how I do it. So I just want to show this to you to try to, again, show that we can take a number of rare syndromes that maybe we're not familiar with and look at them from these various aspects of intellectual disability level, sensory deficit, seizure, neuromotor dysfunction, behavior, communication issues, and things like that. And that will sort of give us the universe of the factors that we need to consider when thinking about people with intellectual and developmental disability. Really, these types of things overlap. And the concept is that as these overlap, and I think you can close your eyes and you can imagine that any one of these areas, if there is a quote disability, the level is so great that it is a disability, intellectual disability, or a psychiatric behavioral disability of some kind. The more that those areas overlap, the more areas that are affected, the more complex the person's presentation might be. So somebody on this Venn diagram who falls under, let's say, area 1, where you're just looking at an athlete who only has intellectual disability, might be exceptionally easy to work with, not really medically complicated, and not much to think about there from a medical standpoint that would be different than, let's say, anybody else. As opposed to somebody who might be in area 4, where they might have intellectual disability and communication disorders and sensory issues and neuromotor issues, behavioral issues. And so that person will become eminently more complex in their presentation. And this will have an impact on their lifespan. Just as an example here, showing how intellectual disability becomes, as the level of intellectual disability increases, the life expectancy for the individual decreases. And that's because there is a correlation between the level of intellectual disability and the level of other overlapping disabilities. As an example, from my clinic here, I'm showing individuals in my patient panel that have mild, moderate, or severe and profound intellectual disability, and the percentages of those individuals who have other overlaying medical concerns that are common to neurodevelopmental disorders, such as seizures, autism, neuromotor issues, and psychiatric. And you can see each one of those categories becomes more prevalent the more significant the intellectual disability is. So the first thing to keep in mind is that people with intellectual disabilities are living significantly longer than they ever have in human history. Just 100 years ago, you're looking at average lifespans that were less than 20 years of age. And now you're looking at average lifespans that are well into the 60s. And what that meant, though, for those of us in the medical field, was that intellectual and developmental disabilities was relegated mainly to the area of pediatrics. Those of us who went into the adult world typically didn't get a lot of training with people with IDD. And so unfortunately, what that means is a lot of the adult practitioners out there really haven't had a lot of training. But as you can see from this graph, a lot of people, in fact, there are now more adults with intellectual disability than there are children with intellectual disability. So there's been this massive demographic shift. Accompanying that, so this is a bit of a complicated slide, but what this shows is the demographic trend of people with intellectual disabilities moving out of institutions. So prior to the late 1990s, people with intellectual disabilities, for the most part, lived in institutional settings, meaning that they were not really expected to be cared for by general community doctors. However, after the late 90s, the majority of people with intellectual disabilities lived in the community. And so that meant that we had a responsibility, the medical community had a responsibility to begin caring more for this population. And keep in mind from my last slide that this was also an older population. The problem is that most physicians at the time, and this is not unique to physician training, this is also true of dentists and nurse training, just about any kind of training in the healthcare professions. Really, there just was no concerted focus on people with intellectual disabilities, and certainly not adults with intellectual disabilities. This graph here shows a survey that was done in the early 2000s that essentially showed that the average medical student received about 11 minutes of training throughout their entire 4 years, 11 minutes of exposure to people with intellectual disabilities, and that story didn't get any better when they got into internal medicine residency or family medicine residency programs. And this creates a little bit of an issue. And so this is something called the Dunning-Kruger effect. And this is something I always caution my clinicians who are first getting into taking care of people with intellectual disabilities, is to be wary of the Dunning-Kruger effect. And essentially the Dunning-Kruger effect says that when you first learn about something, you aren't exactly aware of what you don't know. And so your confidence level tends to be a little bit higher than your knowledge of the subject should allow for. And as time goes on and you learn more, then you become more aware of the things that you don't know. And then as time goes on further, you enter into this realm of expertise where your confidence and your actual knowledge match. And we want, of course, people to be more into that side on the very right, where they have an accurate match between what they think they know and what they actually know. But because of the lack of training in medical schools and the lack of exposure of most clinicians in this field, there tends to be sometimes an overconfidence in when clinicians are approaching people with ID. And this leads to something that, if I could boil down the biggest danger to people with ID in the medical profession today, it's diagnostic overshadowing. And so let me walk you through what that might look like. Diagnostic overshadowing is essentially when you blame a new medical or behavioral problem entirely on an existing disability. In other words, it's sort of being blindsided by a syndrome, perhaps maybe that you haven't heard of or aren't quite sure about, and then just sort of blaming it on that. So a classic example that we've seen a lot is somebody who is being cared for at a group home, and somebody observes a behavior that maybe a caregiver observes a behavior that they find to be problematic, and that behavior is alerted to family medicine or a psychiatrist, for example, and the typical physician will respond by looking to medicate the behavior. Perhaps the person is hitting themselves or being aggressive, so they prescribe some kind of medication that addresses the behavior. And the thing is that most of the time when you prescribe a behavioral drug, it works and the behavior decreases. The problem is that maybe it wasn't due to just the fact that they have autism. Maybe it was due to something else. And in fact, often it is. So if you weren't astutely looking for, let's say, a dental abscess or an ear infection, and you prescribe an antipsychotic instead, well, the behavior might go away for a little bit, but the problem that is underlying that behavior is going to get worse. And then eventually the behaviors will increase again. Now, the problem is if the physicians who are involved in this cycle of diagnostic overshadowing don't ever get to the bottom of the complaint, they're in danger of thinking, oh, well, gee, we prescribed the medication the first time and it worked. Let's just do that again. And so they do it again. And unfortunately, what that leads to is a lot of overprescription in this population. If you have intellectual disability, you're 25% more likely to be given a prescription, but you're 300% more likely to continue that prescription. Once physicians prescribe these medications to this population for a lot of different reasons, it's very likely that these individuals are going to continue those medications, and that leads to a lot of polypharmacy. And in fact, when we've looked at why individuals have psychiatric or seizure drugs that are being prescribed to them, almost half the time there's no corresponding psychiatric diagnosis, and 1 out of 8 times there's no corresponding seizure diagnosis. Oftentimes these drugs are just being handed out for a temporary behavior, and then they're never taken away again. And unfortunately, that can lead to a lot of long-term side effects. And this is something that is relevant to Special Olympics. For example, cardiac arrhythmias. About 5% of Special Olympics athletes are taking some kind of medication that can cause a cardiac arrhythmia, like long QT syndrome. And long QT syndrome is a significant risk factor for sudden cardiac death in athletes. So this is something that we really have to watch in our everyday lives working with people with intellectual disabilities. Additionally, there's other side effects that can happen because of these various drugs: mood changes, obesity, diabetes, osteoporosis. You noted from those previous slides that obesity and osteoporosis levels are certainly higher, so is diabetes. Constipation is another big issue that we see a lot in this population. Dental disease, gastroesophageal reflux, high blood pressure, so many things. All right, so let's stop and do a quick knowledge check here. Which of the following are true of people with intellectual disability? Select all that apply. They all have a neurodevelopmental disorder. They all have autism. Some have seizure disorders. Some have neuromotor dysfunction. Well, all that apply, they all have a neurodevelopmental disorder. Some have seizure disorders, and some have neuromotor dysfunction. Not everybody who has an intellectual disability has autism, though there is some significant overlap. Another knowledge check question. Most people with intellectual disabilities in the world alive today, A, will die before the age of 30, B, will be diagnosed with autism, C, are over the age of 18, D, will develop Alzheimer's dementia. And I'll show you the answer here. The answer is most people with intellectual disabilities alive in the world today are over the age of 18. Again, there are more adults with intellectual disabilities than there are children today. Here's a case scenario for you. You are covering the football venue at Special Olympics, I should say soccer. You notice an athlete on the sidelines who is pacing back and forth and looking agitated. She appears to be in her mid-20s and has an almost pixie-like face. She periodically slaps the side of her head with her right hand. You ask her coach what is going on. She says she's been doing this for the last 3 months. With respect to the behavior, what should you do? Choose one. So A, ignore it. This is a longstanding behavior and it's normal for her disability. B, refer her to emergency psychiatric services. This athlete is self-abusive. C, refer her to a dentist. Maybe she has a toothache. D, tie her right wrist to her belt loop so she'll stop hitting her face. All right, we'll go through these and I'll just explain these very briefly. So ignore it. The longstanding behavior is normal for her disability. Well, that sounds a lot like diagnostic overshadowing right there. We don't want to ignore some kind of behavior like this, especially a self-abusive behavior. Second, refer her to emergency psychiatric services. The athlete is self-abusive. Well, it's true, she is slapping herself, so she is self-abusive. However, from a psychiatric standpoint, from a behavioral standpoint, there may be something else going on. The clue in this case is where she is, what she is doing, and where she is hitting herself. And in this case, sometimes that can be the way that she is hitting herself may indicate where the pain actually is in somebody who has limited verbal ability. So in this case, C, we're going to refer her to a dentist because maybe she has a toothache. Let's rule that out first. And then D, tie your wrist to a belt loop so she'll stop hitting her face. Obviously, we don't want to be restraining anybody physically, and that's clearly not going to treat the issue. And I bring the dental up again because I want to show you this real world example from a Special Olympics athlete years ago in my local Special Olympics. This was an individual who we saw at a Special Smile screening, and it was clear that she had some behaviors. She had been on a number of psychiatric medications, and then we got her to a dentist to do some x-rays. Everywhere you see a yellow arrow there is a painful dental abscess. This is essentially a bone infection. There's a lot of those there. This person was in immense pain, and when finally got into the dentist to get these abscesses treated, she fell asleep for 48 hours afterwards, finally finding some significant relief. The good news about this particular case was, of course, she was taken out of pain, but aside from that, the medications that she was on were able to be discontinued, the behavioral medications. Again, she didn't need to be on them. It was that whole concept of diagnostic overshadowing that had led her into that path. And we were able to really get her on the right path where we identified the proper cause of her behaviors and were able to treat that. Here's another case scenario. The coach of a teenager with autism complains to you that he has been acting differently lately. The boy, who also has a seizure disorder, has been irritable and aggressive toward his teammates lately. Sometimes he will repeat short verbal phrases to himself. The coach has seen this type of behavior before from the boy, but not for a long time. So, what is the primary cause of his behaviors? Choose one. A, autism. B, a change in medication dosage. C, sexual attraction to a new assistant coach. D, constipation. E, any of the above. The answer, of course, is any of the above. Now, I'm focusing a lot on behaviors here because this tends to be something that will throw our volunteers off if they encounter it in our athletes. But it's important, again, to get back to this concept of diagnostic overshadowing and to understand that any number of factors could contribute to somebody's behaviors. So it's possible the individual might have autism. However, they may have changed the medication dosage. Frequently when our athletes travel to a large games event like USA Games, they might miss a medication. And so that might have something to do with it. They also are going to meet a whole lot of new people, and sometimes maybe they have an appropriate or an inappropriate reaction to those individuals, such as a sexual attraction. And constipation here. A lot of times when people are traveling, they're not hydrating well, they're not eating well, and this, of course, can lead to discomfort. So keep thinking about any of these kinds of causes. Here are some other non-pain causes of behavior. Thyroidal changes, hormonal changes, vision or hearing changes, vitamin deficiencies, grief, abuse, dementia. Notice I put psychiatric and psychological issues toward the bottom of the list because I want us to consider those things as toward the end of our differential. And the last thing, of course, which I mentioned before, is missed medications, which is something that is quite common at a Special Olympics event. So one of the more important things to keep in mind as we're trying to avoid something like diagnostic overshadowing is to make sure that we address the communication differences that might exist with individuals who have intellectual disability. These differences can be unique and can occur to varying degrees. As an example, of course, we might have people who have a limited verbal expression or limited ability to comprehend verbally. They might take longer to process things that are being told to them. Some individuals might use communication devices. But I think one thing that I like to point out is that typically people who have limited verbal communication in my experience anyway, tend to have a little bit more sensitivity to nonverbal communication. I always like to give the example of vision impairment and how it's known that the sense of touch or the sense of smell or even the sense of hearing can become more sensitive to people who have vision impairment. Similarly, people who might have some kind of a difficulty in verbal communication tend to be a little bit more sensitive to nonverbal communication. So it's important to remember that as you're communicating with people with intellectual disability. But there's a couple of other tips here just to think about. First, when you're interacting with somebody who has an intellectual disability, you always want to speak directly to that person. This is probably one of the most common complaints that we as practitioners get from people who have intellectual disability. When they complain about the healthcare system, they say, you know what, my doctor never talks to me. He always talks to my mom or my caregiver. And, you know, I might be 35 years old, but the fact that I have intellectual disability apparently means that my doctor is just going to ignore me. And of course, we don't want to put anybody in that kind of situation. So always try to speak directly with the individual, with the athlete. Also, it's important to speak to the athletes in an age-appropriate manner. Again, just because somebody might have a longer processing time or some cognitive impairment, it doesn't mean that they have the mind of a 4-year-old or an 8-year-old, and you need to speak to them as if they were a child. It's always best to go with the age-appropriate type of speech. And if they want to deviate from that, then they'll let you know. Again, be very cognizant of your own nonverbal communication. Sometimes you can communicate things that you had no idea that you were communicating, not because of what you say, but how you say it. Now, it does sometimes help to use simplified language for people with intellectual disability. And sometimes it also helps to be very concrete about what you're asking somebody to do. So, of course, we like to show and do and explain what we're asking the athlete to do. So here's a couple of other tips around using language when you work with people with intellectual disability. So here's a couple of things to avoid. We like to say person-first language because we want the person to be considered first. So you don't want to say things like the disabled, you say a person with a disability, or please, something like he's a Downs, as opposed to a person with Down syndrome, or somebody who's confined to a wheelchair, say instead person who uses a wheelchair. Sometimes people get confused and they want to know, gee, how do I say the word normal in this context? And of course, we try to celebrate diversity and neurodiversity in Special Olympics, and when we work with people with intellectual disabilities. So we try to avoid words like normal. Sometimes medical folks may say neurotypical, and that could be an acceptable term. And also, please, please, please avoid the use of the R word. You've heard me use intellectual disability. Using the R word will take us back a good 20 years in terms of social progress. So please avoid that word. Here's a case scenario for you. You encounter a 23-year-old gentleman with Down syndrome because his Special Olympics coach is concerned about his decreased appetite over the past couple of days. You shake your hands with him and you introduce yourself. The patient's name is Waleed, and he tells you that he is a basketball player and a runner. He hasn't had any physical complaints, and he says that he's really, really healthy. Upon physical exam, a midline vertical scar is across his sternum. You ask him about it, and he tells you that he had a surgery when he was young. As you palpate his abdomen, you notice that he winces when you reach the upper right quadrant. You pause for a moment, and you wonder to yourself if cholecystitis is more common in people with Down syndrome. You ask the patient to sit up so that you can continue on with the physical examination. As he sits up, Waleed bursts out into tears, and he tells you that he is scared. So here's your question. Why did Waleed cry? A, the patient has a labile affect, probably due to too much thyroid medication. B, you palpated the right upper quadrant too forcefully. C, Waleed has an anxiety disorder and should be prescribed a benzodiazepine for future visits. D, you may not have been aware of what you were communicating non-verbally, that he had something to worry about. So the answer is, of course, D. In somebody with Down syndrome, of course, thyroid issues are very common in Down syndrome, and it's theoretically possible that somebody could have a thyroid issue that you may think about. And of course, it is always possible to do too forceful of an upper quadrant palpation. I certainly wouldn't want to jump right to prescribing benzodiazepines for the next medical visit, given all of our discussion about diagnostic overshadowing. But this story actually is a real life scenario that happened to me. And it really was about nonverbal communication. And what happened essentially was, as I was thinking about whether this individual might have had some cholecystitis, I got this sort of a little bit of a worried look across my face. I didn't say a word to the patient. I was nice and as friendly as could be throughout the entire thing, but he very perceptibly picked up on the change in my facial expression. And that was enough with me and my white coat and my stethoscope, and that slightly worried look for about 2 seconds was enough to scare him. And so again, just be very cognizant of what you share non-verbally, what you communicate non-verbally. Okay, so a little bit, just some practical information here. When you're working with our athletes at the Special Olympics event, you may encounter the medical form that they filled out here. It's a 4-page form. It is a fairly exhaustive form. It contains a lot of demographic information and a lot of pertinent medical information that is pertinent for sports activity, including their last physical exam. It's important that you know, just as a matter of course, that all of our athletes have had to have a sports physical prior to participating in these games, and that those sports physicals have been screened for some of the more significant issues that we should be concerned about with our athletes. So as an example, cardiac issues, seizure issues, spinal cord issues, concussion, asthma, heat illness. These are all things that we've been looking for. And it's important that we do, and I just want to share these with you, not to scare you, but just to elevate your awareness that we're going to see more of these in Special Olympics athletes. So as an example, we know that cardiac defects are at least 10 times greater in the Special Olympics population, and which means that there is a significantly greater likelihood of a sudden cardiac issue that might occur. Seizure disorders, again, about 25% of our athletes are going to have seizure disorders. However, at USA Games, this is a smaller group, perhaps more like single digits, less than 10%. However, it's something that is important to consider with seizures. One thing that I have not mentioned yet is something that I call anti-doping, and this is something that does occur in Special Olympics athletes. So we typically aren't going to find athletes abusing performance-enhancing drugs, at least not in the classical sense in Special Olympics. You're not going to find a lot of steroid abuse and things like that. However, many of our athletes are aware that there are drugs, and seizure drugs is one of those classes of drugs, but other drugs might be benzos and benzodiazepines and antipsychotic drugs that do decrease athletic performance, that kind of slow somebody down. And so it is not uncommon for some of our athletes to intentionally skip some of their medications when they're when they're competing. So this is just something to be aware of when you're evaluating an athlete, is to find out if they are up on their medications and if they've been taking them faithfully while they've been on site. So, of course, spinal cord injuries is something else that we look at Special Olympics. Concussion, there's going to be a whole different training on concussion, but it's something that is a little bit more tricky to evaluate in Special Olympics athletes. Again, about 14% of our athletes in Special Olympics will have asthma, about 10% at USA Games will. And as I mentioned before, there are about 25% of our athletes take medication, which somehow impacts sports performance. In this case, during summer games, we have to be very cognizant of the fact that about 10% of our athletes are taking medications that can predispose somebody to heat illness. So we have to be very careful about heat. Some more specific information about our athletes and these games for Orlando 2022. You can see about 5% of our athletes have diabetes. About 3% have a cardiac murmur that is significant in the upright position or of a significant size. About 11% of our athletes have high blood pressure. A number of our athletes have easy bleeding issues, sickle cell disease as well. And also a number of athletes have marked that they have hepatomegaly or splenomegaly, which of course is going to put them at risk if they're involved in certain sports that might involve trauma. Again, we've screened most of these athletes for these issues, and we have raised the awareness to appropriate individuals if there are any matches between, for example, somebody who might have increased likelihood of injury from in a traumatic sport, and if they're participating in a sport that might produce that injury. A couple of other issues to talk about: atlantoaxial instability. This is something that is common in people with Down syndrome. At USA Games, only about 5 people who have this particular issue. However, it can be debilitating with the wrong set of circumstances, could end up with severing the spinal cord. So this is something that we watch out for very closely. One thing that's going to be on everybody's mind for these games is COVID. And so we have asked our athletes to tell us about their COVID experiences. What we found is about 14% of our athletes have had a known COVID illness. About 95% are going to be vaccinated by the time that they're participating in the games. This and a lot of other medical information will be held in the RACESAFE system, and there will be more discussion about how you use the RACESAFE system in a different training. One thing that is important to note is that on the credential for all of our athletes, you will find perhaps some symbols that look like these that indicate different medical issues that will be important for emergency personnel. So notifications about allergies, food allergies, insect allergies, asthma, bleeding, sickle cell seizures, diabetes, high blood pressure, vision, hearing impairment. So if you have any questions about an athlete or you encounter them, one of the easiest things to do in order to get some very pertinent and very quick medical history is to just look on their credential and see if you see any of these particular logos. Finally, as you are going through and evaluating athletes as they're participating in games, it's important to think of a few reasons that you might actually sit somebody out. First, I want you to understand that though our athletes can be somewhat complicated in their presentation and are predisposed to be a little higher risk, the fact is the vast majority of our athletes are going to be able to participate in their sport of choice without any real concern. However, there are some things you may encounter that are going to deserve some extra scrutiny and would be good reasons to sit somebody out. An example would be a suspected concussion, a confirmed high blood pressure of 160 over 100 or higher. That would be either a systolic of 160 or greater or a diastolic of 100 or greater. Symptomatic hypotension, any new onset cardiac arrhythmia, any new neurological signs, especially those that could be affiliated with a spinal cord compression. Now, it's important when you think about neurological signs that we want to consider things that are new. In our athletes, of course, we have a lot of neuromotor issues that are long-standing, and those typically are not going to be a reason to sit somebody out. So it's important to get to know the athlete and to know what's new for that athlete. Of course, spleen or liver enlargement, especially if it's new, any kind of acute viral infection, and obviously during the games 2022, COVID will be a concern to think about. And of course, any other emergent or urgent issue. I would like to thank you so much for listening to this presentation. If you have any questions, I have provided my email address here, and I'd be glad to discuss anything in this presentation or any questions you might have about athletes with intellectual disabilities. Thank you.